Hello, my name is Dr. Dadoyan. It's a pleasure to be here with you to present on this topic. This slide is the list of the CME Planning Committee members and their disclosures. I have no financial disclosures for this lecture. A little bit about myself. I am a board-certified psychiatrist with a subspecialty certification in consultation liaison. I do quite a bit of geropsychiatry work. It is work that I enjoy and find it very important. It is, again, a pleasure to be with you today and discuss this topic. We're talking about agitation and psychosis in geriatric patients, specifically in ambulatory settings. Agitation and psychosis in older adults are conditions that are encountered increasingly more frequently in various clinical settings, including ambulatory settings. They occur more frequently in persons who have cognitive impairment or dementia. Some definitions: psychosis, we tend to use a more narrow definition of that these days. So hallucinations, delusions, specifically disorganized speech for schizophrenia, used to be more broad definitions of disorganized behavior, lack of functioning, which are things that we may find relevant in our topic today. Regardless of the diagnostic definition, impaired reality testing is a very important concept in psychosis. That means that whatever experiences the person is having, they believe that they are real. So sometimes people may hallucinate and think that, there's just, I'm having this experience, it's not real. But if you believe it, then there is an impaired reality testing, which makes it a more psychosis. Agitation, restlessness, pacing, labile mood, escalation to property destruction, verbal physical aggression are all within the agitation spectrum. So let's talk about some of the conditions that may pertain to agitation and psychosis in an older adult. You have the primary psychiatric conditions, which would be things like schizophrenia. You have the secondary psychosis, which is delirium, medical conditions, and a number of things that can give rise to a secondary psychosis, substance use, another one, and importantly, cognitive impairment or dementia. Dementia-related psychosis is really the most common cause of late-life psychosis, 40 to up to 50%. There's a lot of statistics around this topic. Just agitation occurs in 40 to 60% of persons with Alzheimer's dementia, and there's a lot of other associations with other types of dementia as well. A little bit of nomenclature. So currently, it's been a while, DSM-5, but major neurocognitive disorder is dementia. Minor neurocognitive disorder is mild cognitive impairment. The terms are used interchangeably. So the older adult population is increasing in the US as well as globally. There's a significant proportion of people who have cognitive impairment as well as mental health and substance use problems in the population. Let's talk about 2030. That's the year when the youngest baby boomer turns 65. 1 in 5 Americans will be 65 or older. Some statistics: 10 to 14.4 million Americans aged 65 or older will have mental health or substance use disorders. 7.7 million people aged 65 and older with Alzheimer's in the United States in 2030. Jumping on to 2060, 98 million Americans will be over the age of 65. 1 in 4 Americans will be 65 or older. And another statistic: 50% of persons who are above the age of 65 in the US currently live in 9 states. California, Florida, New York, and Texas are the top 4 states. This slide is, I'm borrowing from the editorial from Dr. Roberto in Geriatric Psychiatry 2021. This basically want to emphasize the fact that the elderly population is a population at risk. Here they speak about a triple jeopardy in terms of ageism, mentalism, and ableism, of which older adults often have all three. So ageism is a bias against people who are older, mentalism bias against people who have mental health conditions, and ableism with people, a bias against people who have disability. And my addition to this will be really the social determinants of health in older adults, and this is all the things that pertain to, for example, where they live, financial disadvantages, access to care, access to transportation, access to healthy food, safety. So all of these things. And in terms of a risk model, this is probably more a multiplicative risk model. Let's talk about the persons who take care of older adults, the geriatric workforce. I'm just going to touch on some shortages and trends. So all medical specialties will, of course, be increasingly exposed to a growing geriatric population with complex psychiatric and medical care issues that are often overlapping. Overlap is an ongoing theme in this talk and generally in this population because there's always more than one thing going on. Internal medicine and family medicine. Geriatric subspecialties show a decreasing number of applicants, and of the geriatric internists, only 50% actually end up recertifying, which is less compared to other internal medicine subspecialties. Talking about geropsychiatrists and geropsychiatric workforce. Fewer geropsychiatric fellowship training programs are available at this time, and only 50% of the positions are actually filled. Increasing number of consultation liaison fellowship training programs with a higher percentage filled. So there's some idea that that may be a way to help or close the gap. And there's a lot of focus on recruiting professionals across multiple different disciplines to improve geriatric care and specifically psychiatric geriatric care. So perspective from geropsychiatry, which is kind of what my subspecialty is on the interface of medical and psychiatric conditions, inpatient or outpatient. Geropsychiatry and consultation psychiatry are subspecialties with shared beginnings and also natural continued affiliations. Some campuses have both present, and that's, of course, an advantage, but a rarity. Usually, consultation liaison psychiatrists are going to be providing the bulk of hospital care for older adults, and as well psychiatrists who provide consultations. There is a possibility of thinking of subspecialized consultation liaison psychiatrist in order to close the gap a little bit. So let's go into an initial approach of older adults with agitation, psychosis in the ambulatory setting. Important thing is to, of course, realize first, what is the acuity of the situation and what would be an appropriate setting of care? So maybe the ambulatory setting may not be. You have to decide whether it's a primary versus secondary cause and understand if there's any medical issues or substance use issues that are contributing to the situation that may be needing to be addressed in the immediate. Some of the concepts that we think about is, are they able to accept care in the home? So are they able to accept eating, drinking, just basic hygiene? So those would be important things to see about. Safety concerns are very important. Danger to others is a very obvious thing. However, suicidality in older adults is a little bit less easy to recognize. They do have the highest suicide rate globally. Older adults who have dementia have an increased risk of suicide death compared to people who do not have dementia. And early dementia is often something that is not recognized. Early dementia, depression, and bipolar illness are all associated with a high risk of suicide. So within this setting, that is an important thing to think about, and suicide rates are highest among men aged 75 years and older. This is just a recap of all the things that you already know that may be contributing to a secondary psychosis. The delirium, medical issues, head trauma, substances, infections, malnutrition, of course, dehydration, and the dementia, which may, in some people, have a stepwise progression. So, of course, it's important to rule out the delirium. It's a medical emergency, and it can be difficult to differentiate from dementia. Inability to sustain attention is one cardinal feature of delirium. It's not able to sustain attention, shift attention. And then the course, the longitudinal course, waxing and waning is another thing that is suggestive of delirium, having lucid moments and then kind of going into a confused state. There's three subtypes, and hypoactive, hyperactive, and a mixed pattern. Hypoactive is the most common, and it is easily missed. This is often somebody that might be for several days having either paranoia or experiencing visual hallucinations of animals or other things in their room that may be scary, and they may not share that. And this is also something that increases the risk of suicidality, especially in the setting of other issues. So it's the most commonly delirium is multifactorial in older adults and usually requires multimodal interventions, whether that be environmental ones, they may be treating an infection or what have you, or removing an offending agent, which may also be a supplement that people are using. It's estimated to cause about 10% of all late life psychosis, and multiple pathways lead to delirium. There's a lot of neuronal network disruption, neurotransmitter dysregulations that lead to this presentation of delirium. It's kind of bidirectional with dementia, so it can be a marker of vulnerability to dementia, versus the delirium itself can be causing a permanent neuronal damage, resulting in dementia. So some anesthetics, for example, can cause delirium and cause an acceleration of amyloid beta accumulation with the expected result. Substance use in older adults is a very important topic. People of all ages should be asked about using alcohol or substances, but specifically in older adults, 1 in 11 over 60 had substance use disorder in a study done in 2022. The number of adults age 65 and up who smoke marijuana or take edibles spiked 75% in 3 years, according to a study in 2020 in JAMA. So these things are real. Cocaine use, smoking opium, all of these things are possibly there. And of course, common, and it could be underreported. Lifetime drinking, even in small amounts, can be problematic. Actual prevalence of alcoholism is estimated between 10 to 18%. So the symptoms can be confusing if you don't know that that's what's happening or is a component in what's happening, and it can include insomnia, confusion, cognitive impairment, depression, anxiety, somatic presentations, as well as agitation and psychosis. So if you are having an intoxication or withdrawal symptom to manage, it is more complex to manage in older adults. There is sometimes refusal to treat due to stigma or denial. It's in the setting of an older adult that's having traumatic brain injury or recurrent traumatic brain injury, it should be a trigger important to consider co-occurring PTSD, seizures, and substance abuse. Alcohol is the second most important factor for suicidality in older adults after depression. And of course, remembering the pharmacokinetics for older adults, lean body mass is reduced with aging, resulting in a reduced volume of distribution and increased peak ethanol concentration. This accounts for about 10%, that substance abuse, for 10% of all late life psychosis. So let's focus on the dementia-related psychosis as the most common cause of late life psychosis, maybe up to 40 to 50% of cases of late life psychosis. So it is, of course, the agitation and psychosis are within the part of neuropsychiatric symptoms, which occur in more than 97% of persons with dementia eventually. It is important to recognize NPS. For example, in mild cognitive impairment, the presence of NPS, which is also more than just psychosis and agitation, it implies a worse prognosis that it may progress to dementia. It is a good time to think about interventions to be more preventative at that time. Of course, dementia-related psychosis is a heterogeneous population, and there is advancing knowledge and improved insight into the biology and specific clinical phenotypes that will bring better understanding, hopefully. And you might imagine that, especially with this population, you may have people who actually have a primary psychiatric disorder that was either undiagnosed or undisclosed, or the person is, at the time that you're receiving them, unable to give you that, provide you that actual history. So when people with cognitive impairment have psychotic symptoms, the presence of hallucinations is generally associated with more functional problems and decline. Delusions in Alzheimer, of course, common. Delusions of theft occur earlier. And later on, it's more things like misidentification syndromes, the TV sign, where the older adult might believe that person's characters in a TV show are actually real people and they are involved in their lives, and phantom border, which can all happen later on in Alzheimer's. The misidentification syndrome is one common one is Capgras, where they think that the spouse or the family has been replaced by a lookalike who is an imposter. The mirror sign is another one where people may look in the mirror and not recognize their own reflection. So let's move to the primary psychosis in older adults, which of course can be associated with psychosis, schizophrenia, schizophrenic brief psychotic, which is in relevance to the length of the illness, schizoaffective. Generally, these first four, and especially schizophrenia, have a functional decline. It's kind of a broad condition affecting multiple things, and generally has a functional course that is on a decline. And you have delusional disorder, we'll talk about that. And you have the affective psychosis, meaning bipolar with psychosis or a unipolar depression with psychosis. So it is rare, the primary psychosis like schizophrenia and such in older adults. However, the absolute amount is increasing because of increased life expectancy. And we're doing a better job with medical treatments and increased life expectancy. But as a result of that, you have some of the statistics that we're seeing. And one of that is you will be seeing more older adults with primary psychosis. We do talk about late onset schizophrenia also, with an onset after age 40. This is a known thing since the beginning of diagnostics of schizophrenia. It accounts for 15 to 20% of all schizophrenia cases. And then you have the very late onset schizophrenia after the age of 60, which is a rare condition, but it does happen. Prevalence of schizophrenia over the age of 65 can range from 0.1 to 0.5% in the community setting. So I did want to touch on this delusional disorder in older adults. It does happen and may come to clinical attention in the ambulatory setting. Usually these are non-bizarre delusions. Unlike schizophrenia, it's not associated with the lifetime of lower functioning. The functioning is only affected by the specific delusion that the person has. Typically, non-bizarre meaning that it is something that can happen in real life. It could be a somatic one of having an illness, a delusion, or partner having infidelity, or persecutory, where they feel like they're being followed by somebody. Other aspects of their life are not affected unless it is related to the delusional belief. Prevalence is difficult to tell. Typically, they will not come for treatment. They do avoid treatment. They don't enroll in research. So it's kind of hard to really know a lot about this. Schizotypal or paranoid personality disorder can be a risk factor. Antipsychotics can be effective here, is because it can obviously, in addition to the psychosis, cause agitation. In refractory cases, even ACT has been successful. So it depends on how bad it is, how it's affecting their functioning, and that's going to guide what treatment they need. For some persons with delusional disorder, cognitive behavior therapy can be an effective approach. So here, we talked about the primary psychiatric issues and the schizophrenia, and I wanted to kind of just touch on the overlaps of schizophrenia and dementia. We talk about, the default mode network and the prefrontal cortex. So the default mode network is the one that's active when we're in rest period. It supports our internal mentation about ourselves and the external environment. It also supports internal, like fantasy states. The DLFP, or the dorsolateral prefrontal cortex, is the one that's activated during focused cognitive tasks, and it would be deactivated during rest period. So it switches back and forth, as you might imagine. The salience node facilitates the switch. So in terms of how that affects our topic, dysfunctional interactions can cause salience to be inappropriately assigned to external events. So cognitive deficits and schizophrenia are related to hyperactive, hyperkinetic activity there. So sometimes internal fantasy states are misattributed to being real in the external environment. So that's relevant. And these DMN connection issues can indicate transdiagnostic endophenotypes for social dysfunction that is present in Alzheimer and psychosis. So these are all interesting moving forward directions and better understanding of this important overlap and hopefully relevance for treatment and prevention as well. Some other, neuroimaging also shows similar patterns of white matter deficit. Both conditions show cholinergic dysfunction, and there are shared genetic factors. So summing up on these serious mental conditions, in terms of older adults. So the number of people is expected to triple over the next 25 years. So we talk about SMI, I mean schizophrenia, schizoaffective, and bipolar illness. So one important statistic, older adults with the recently discharged from the inpatient psychiatric units are twice as likely to die the year after. 75% of this is related to medical disorders, cardiovascular, or respiratory disease. So within this talk, I just also want to kind of mention these statistics in terms of things that are we can think of as preventative approaches, knowing what actually happens and what are the stats. Mortality rates are higher in older adults in serious mental illness than those without. And for people with bipolar illness, 80% have comorbid medical problems. So let's move to the bipolar disorder. So bipolar disorder may have a late onset after the age of 50 without a personal or family history of bipolar disorder. However, most of these cases are actually secondary mania, meaning we need to figure out what is the actual cause. Treatment is kind of the same, but of course, we need to identify that etiology if it's secondary. Common secondary causes are CNS insults, injuries, strokes, can be diabetes, thyroid issues, and of course, medications like steroids and certain antibiotics. Older adults actually comprise 25% of all bipolar patients, but in the case of older adults, mania is a more debilitating condition. Moving to depression. So depression in older adults may look like depression in younger adults, but there are some differences, demographics, prognosis. Important concept is the late onset depression, which may be kind of a different animal altogether. It may have fewer depressive symptoms and more somatic psychotic symptoms and cognitive deficits. There are different pathologies for late onset depression in the absence of previous major depression. It could be things like subtypes relating to vascular, where people have a lot of white matter punctate lesions and an associated depression. It could be things like Parkinson's with a slowing, and it could also be things that are associated with a subtype of older adults that have frailty. And the pathology for this depression is somewhat different from the pathology for MDD or early onset depression. And of course, a treatment may be less effective for these. And usually we also try some neuromodulation approaches for late life depression, which may actually be a little bit better for that. Suicide rate is, of course, higher, more in men, 1,500,000, women, 16. And another important concept for depression in older adults is that the rates of major depression are actually lower. However, mild depressive symptoms are highly prevalent and they are associated with debilitation and psychiatric morbidity. So depression with psychosis is more prevalent in older depressed patients. Important that also to realize that the delusional content may persist after the depressive episode resolves. So the reasons for that may be different, but then you do have a decision to make on to treat or how to treat that aspect. Preoccupation with a particular thought or idea is common with depressed elderly persons. Severe depression can also be associated with negative auditory hallucinations, and these could include command hallucinations that tell the older adult to harm themselves. And this can occur in the setting of impaired reality testing, meaning that they think the voice is actually a real thing and presumably possibly follow the command hallucination. So just to sum up, the newer research definitely suggests that the late onset of depression is a marker for dementia risk compared to early onset, with the late onset depression also possibly being a prodrome of dementia. Let's move to anxiety conditions. So there is a bidirectional relationship between anxiety and dementia. There's some anxiety conditions that have neurobiological consequences, such as hippocampal damage, that lead to cognitive impairment. On the other hand, persons who have no prior anxiety, when they develop early dementia and they are aware of their cognitive deficits, they may have anxiety and also associated agitation, frustration when they can't remember or they begin to realize that something is going on. Age alone is never the etiology of anxiety symptoms. New onset of anxiety in late life, especially in the context of mild cognitive impairment, should prompt further medical evaluation. Overall, anxiety is one of the more prevalent psychiatric conditions, about 10% in the community, 20% in medical settings. And it may, again, present with that agitation, restlessness, pacing, irritability, especially in the context of cognitive impairment. And psychosis can occur with this, especially with PTSD. Speaking of which, I want to close with just reminding about the trauma-informed care, which is important, again, in all aspects of medical care. Older adults with post-traumatic stress or acute stress may present with agitation, psychosis, or both. Collateral information is critically important, especially when people are not able to provide that history or context. And it is very important to identify triggers, especially in thinking about the non-pharmacological approaches to managing agitation and psychosis in older adults. Now, the next few slides are going to be mostly about from the practice guidelines on the use of antipsychotic to treat agitation or psychosis in persons with dementia from the American Psychiatric Association. Little repetition, but secondary causes must be ruled out. Pain, including specialty consultations as appropriate, language and cultural barriers, and collateral information from the staff or family. Now, of course, screen and assess for any safety concerns that may require hospitalization is very important. Potential risk, though, to patient and family, of course, you have to personalize that risk as well. I mean, if you have able-bodied caregivers in the home that are able to see them through the episode versus a patient who is with only a single frail caregiver at home may affect decision-making. So when thinking about assessment, we definitely want to try to get some sense of the onset, frequency, and pattern of the symptoms. Other physical conditions, including pain, may need intervention. Hearing and visual loss exacerbations can be related. Environmental factors, privacy needs may be agitating the patient. It oftentimes is a number of things that is causing the syndrome that you're seeing. Bodily functions as simple as constipation may be quite agitating and adding to the mix. Important to know the subtype of dementia, if it's known, because it's relevant for the assessment and treatment. If it's difficult, it may be beneficial for the caregiver or family to keep a journal of the symptoms. And also establishing with the family the presence of distress. I mean, it may be, given the antipsychotics having side effects and concerns, if the patient has no actual emotional distress from the symptoms, even in the absence of intact reality testing, you may choose to not treat. If an older adult imagines that they have a daily phone conversation with a sibling, which does not distress them, that may or may not be something you may be wanting to treat. So it really depends. Presence of psychotic symptoms may also always progress to something worse, but a lot of times it just does not. So you have to kind of balance all of that together and also, discuss those risks and benefits of possible treatment with the patient, family, surrogate decision makers. Of course, in emergency situations, we may have to make some decisions before that, but usually all of that has to be discussed in full with the family and the caregivers and the patient. So you have to definitely assess which setting of care we want to be in. Non-pharmacological interventions are considered to be the gold standard. That's what you want to start with. Let's go through some of the suggested things. So that includes educational approaches for caregivers. You want to promote clear communication. You want to be making sure that they know to use distraction techniques. The communication also needs to be therapeutic and appropriate to the person's level of impairment. You have to promote making active adaptations to the patient's environment because it is, a moving target, and you may need to make different adaptations as the patients, especially with dementia, they may have stepwise decreases in their functioning, and you have to kind of keep pace with that. Focus on any unmet needs that are not identified. You need to reduce stimulation, promote relaxation, and finally promote calm caregiver responses, which also help with caregiver fatigue and burnout, which is clearly a very important aspect of all this. Moving to a couple of short comments from me on the pharmacological interventions. So cognitive enhancers may have overall improvement. Treatment of depression and anxiety when present, obviously helpful. It is critically important to realize when a person has either bipolar, and not necessarily to label it. I mean, some persons have an agitated response to antidepressants. So if we are increasing the antidepressants and things are getting worse, either we may be treating a person who's in fact bipolar and needs different type of medications, or simply that person gets agitated with antidepressants or higher dosages or that particular one. So we have to kind of keep all that in mind. A lot of this can go also already into the range of specialty care. Antipsychotic FDA black box warning. So this is very important. That's the one to mainly discuss. There's a 1.6, 1.7 times increased risk of stroke or sudden death in dementia-related psychosis. So always share that. This initially came out on second generation antipsychotics in 2005, but then in 2008, both second generation and first generation. So Rexulti is a medication that you probably have heard of, has recently been FDA approved for management of agitation in older adults, just agitation. And this is the regulatory precedent, is the first. Next few slides, we'll discuss more in-depth issues with antipsychotic medications as outlined in the guidelines for antipsychotic use in dementia with psychosis and agitation. So back to the specific guidelines, the expert consensus suggests that using an antipsychotic medication with dementia can be appropriate, particularly with dangerous agitation or psychosis. It can minimize the risk of violence, reduce patient distress, improve quality of life, and reduce caregiver burden. Of course, with the guideline document, they are looking mostly in evidence-based, and they're being very stringent in assessing the studies and the evidence in the statements that they're making. We'll hear this a couple times, but studies in older adults are not that many. They're oftentimes underpowered, and there's differences in methodology that make it difficult to draw conclusions. But on the basis of both strength of the research evidence and effect size, moderate and small respectively, the best evidence for second generation efficacy is in treatment of agitation. A lot of this result was driven by findings with risperidone treatment. So risperidone is substantially better evidence for the class, and it has there is moderate strength of evidence for a small effect, similarly for aripiprazole. There's higher baseline level of symptoms and higher baseline antipsychotic dose suggests that if you stop the antipsychotic, there may be discontinuation. So this is something you may be dealing with in the ambulatory setting with the patient being discharged on medication. So these are some kind of a guidance for what do you do with it. So if they're coming with a higher dosage, that could be implying that the discontinuation may be more problematic. This doesn't mean, of course, that, if it's a high dose and there's side effects, so we don't do anything about it. This is many of these things that we're talking about are going to be largely guidance, and it really boils down to the person-centered care and all the things that are specifically going on with your patient at the time. Studies have assessed the effects of discontinuation, and they do suggest that there is a small effect of antipsychotic treatment based on the discontinuation studies. Because sometimes presence of a dose response effect is kind of the only thing that is, in this case, suggesting that there is suggestive evidence, for therapeutic benefits of medication. Now, results may be absent due to the study, like I said, being underpowered, maybe not using a sufficiently wide range of dosages, or other methodology issues. We don't have a published data on optimal duration of antipsychotic treatment in dementia, so the experts are divided also on the optimal treatment duration. 3 months is, though, on a practical level, something that is used. Very small fraction of experts would support to use antipsychotics in this context without any attempt to reduce. So you should be attempting to reduce. So 3 months is kind of it, but depending on the situation, you may be wanting to do that earlier. Age, medical issues, actual side effects, current symptoms, so they're all going to kind of come into the consideration. Strength of evidence for harm. Now, there is consistent evidence that antipsychotics are associated with clinically significant adverse effects, including mortality. And where does this data come from is more from administrative data, which is less rigorous, of course, compared to randomized trials, which are themselves a little bit lacking. However, administrative data also has the advantage of large patient numbers, and that may be a useful thing when you're looking at infrequent events and identifying those. The limited existing research does make it hard to draw conclusions on the individual patient's harm likelihood. So you kind of have to combine all that together and come up with the best option. And again, of course, specialty consultation probably is merited at this time. Significant physical illness, certain medications, aggressivity often exclude subjects, older adults, from research. So that may also be something that explains the gap between clinical trial results showing a perhaps lack of efficacy and the clinician's impressions in the field of efficacy of antipsychotic use. So going back to the side effects, the mortality, other serious side effects have been reported. These include stroke, acute cardiovascular events, metabolic effects, and pulmonary effects. A lot of this is also mediated by a pneumonia risk. The strength of evidence is low. Possibly there is an increased risk for risperidone and olanzapine. There is an increase in risk for all antipsychotic, especially early in the treatment, first and second generation. Risk of metabolic effect is actually not as strong as it is in young adults. Increased likelihood of adverse effects in people with Lewy body dementia or Parkinson's is an important thing to be aware of. They are much more sensitive and can have high adverse effects with antipsychotics. This may also be relevant for frontotemporal dementias. So as we're talking about pharmacologic interventions, I just want to touch back on the pharmacokinetics with the muscle mass, lower body water, increase in fat content. So this really impacts the volume of distribution. So lipophilic drugs, which is most benzos and antipsychotics, maybe used in ED setting as well as ambulatory, will have a longer half-life and longer therapeutic duration. For benzos, you definitely want to use things like Ativan that are less going to linger around less. Hydrophilic drugs like lithium can become toxic more quickly for the same reasons. You want to avoid combining sedating medications, falls, respiratory concerns, and other dizziness, what have you. Remember that homeostatic capabilities are actually lower in older adults, so orthostatic hypotension, getting used to a tremor. So all these things are actually lower in older adults. So the starting low and going slow is always highly recommended. So touching back on those, so when do we think about pharmacological interventions? Again, to recap, emotional distress, inability to accept care, primary psychiatric conditions, and managing dangerous situations are all important reasons. Within all this, remember that oral medication would have a slower onset of action. That's mostly what you'll be using in the ambulatory setting, with at least 30 minutes or more. And of course, would require for the patient to cooperate with oral medication, which loops back to setting of care. But it is important to allow enough onset of action so that we're not giving several things and they all kick in at once and create a difficult situation. Risperidol in itself can be more efficient for psychosis. Efficacy is also suggested for Zyprexa and Abilify. Just Abilify may have some more akathisia and tremor on some people. For Parkinson's or Lewy body dementia, the safer ones would be considered Clozaril, Seroquel, and Nuplazid. Some of this is, of course, specialty care, especially things like when you're having to use things like Clozaril for dementias like Lewy body or Parkinson's. Thinking about just kind of touching on some things that they mentioned, you have to always think about drug interactions, active metabolites for the Seroquel, and norquetiapine has more anticholinergic and more interactions. Something to think about as well. QTC interval, more problematic with Haldol, Seroquel, Geodon, Nuplazid. Hardly be using Fanapt for this, but I do EKGs and repeat them to kind of monitor for the prolongation, which is important, as can cause torcetabon. Long-acting injectable antipsychotics may be indicated in certain older adults with dementia. Caution is necessary to make sure that the person is able to tolerate the oral medication, and that may include an EKG and other things before switching to a long-acting antipsychotic, which will stay in the body for about a month. So may be indicated in certain situations. I want to touch on a few on a few groups of medications that are relevant. So benzodiazepines, of course, first-line medication if there is an alcohol benzodependence, which should be treated. It can be more complex in older adults, important for anxiety, maybe preferable as an initial trial for Parkinson's and Lewy body dementia. Short-acting should be used. Of course, it still has all the cautions that you know about benzodiazepines, especially multiplied in older adults in terms of cognitive impairment, falling, dizziness, dependence may happen also. In this context, I want to also just talk about the antidepressants as a group. Of course, if depression with psychosis is the situation, you may be needing to do antidepressant plus antipsychotic, again, going somewhat into specialty care. All antidepressants are also effective for anxiety conditions such as panic disorder or generalized anxiety disorder. SSRIs are going to be the most commonly prescribed antidepressants. We usually try to avoid tricyclics in older adults. The actual response rates can turn out to be low. Remember, we talked about the late onset depression, which does have pathologies that are a bit different. There are some other neuromodulation approaches, including TMS and even ECT for certain severe depressions, which outside the scope of this talk. Generally, antidepressants can have the same side effect profile in younger adults. and have the advantage of being relatively benign in overdose, which is an important consideration here. Hyponatremia is very important to look at. Highest risk during the first 14 days, especially, I mean, hyponatremia and other side effects, but this may be a good example. You want to think about what else is on. If the patient is also have seizure disorder and they're also on other medications, they also have renal problems, and you're starting an SSRI. So, you know, it's important to actually think about the whole picture. Risk of bleeding, you know, this antiplatelet effect similar to aspirin. You have other options as antidepressants, SNRIs like Cymbalta, which is helpful for pain. Mirtazapine is used pretty often and is helpful for sleep and appetite. The lower the dose, the better, because actually older adults do not process mirtazapine as well, and the higher doses can cause activation for them and not sleep promotion. And finally, Buspar, which just have a different serotonin mechanism and can be a perfectly good medication for management or an adjunct. Just as a reminder, Buspar is not a PRN medication, so it does need to be prescribed regular and not PRN. Pharmacologic interventions, including here the mood stabilizers. Symptomatic treatment of secondary mania is similar to primary mania, we already mentioned, and mood stabilizers are going to be first line, along with adjunctive treatments, which are often antipsychotics. Mood stabilizer like Depakote is a viable option. There's not a lot of evidence that it's more efficacious versus lithium. However, of course, with lithium, as we noted, risk of toxicity can be high. Sometimes we combine the two. So again, that goes into more specialty care. Remember, again, when you're looking at an older adult, you have to look at everything. So if they have all this and they have malnutrition and their albumin levels are low, so the Depakote level that you're getting is not really telling you neither on the therapeutics, because the free fraction is more. So you want to go clinically, because it may be doing more for you than what the level is suggesting. So you have to go clinically, but also too, you may have more toxicity than you might imagine from the level. So that is another consideration. Of course, lithium, same as with younger adults, caution with certain diuretics, ACE inhibitors, NSAIDs, or in the context of the older adult having actual renal impairment or your urinary tract infection. So in summary, non-pharmacologic management remains the gold standard. You got to clarify the goals of treatment when you use the pharmacologic management. You have to monitor for the side effects as noted. You need to clarify that length of treatment appropriate for the patient. So you need to have that maybe information about recurrence when previously, let's say, Seroquel was discontinued. You want to try to taper within 3 months or even earlier. So on this topic, I wanted to kind of end with a couple of slides from this Cochrane Library Review in 2022. So there is low quality evidence that they may be successfully discontinued in older adults who have been taking it for at least 3 months and may have little or no important effect on the symptoms. Most of these symptoms may be intermittent and do not persist for a longer time. Obviously, you might imagine if all other things are addressed as well. So the discontinuation may have little or no effect on the cognitive function. And also, it was uncertain based on the review that if antipsychotic discontinuation happened, it was uncertain if that led to decreased mortality. Finally, patients with psychosis, aggression, or agitation that respond well to long-term antipsychotic use, or the persons who have more severe NPS at baseline, may benefit behaviorally from continuation. That just has to be looked at carefully and documented carefully. Discontinuation in some people can cause a benefit for the agitation. These conclusions are kind of based on few studies, so further evidence is required to make a comment on that. And finally, the overall conclusions of this review were not different from what they did in 2013, so kind of the same situation. I want to quickly comment on care transitions. from acute settings to ambulatory. So care transitions in general is a critical and potentially dangerous time for older adults in terms of medication reconciliation and other aspects, including getting confused between change of environment. Untreated or partially treated mental conditions in the acute or subacute setting may really impact the ability to perform ADLs to function, can be associated with agitation behavior at home. This can end up with admissions and readmissions, and importantly, institutionalization, which is something we try to delay or avoid. And of course, medications that are there that don't need to be there during that transition is an important thing to look at. So I'm going to conclude with a couple of slides on prevention, which I think is one of the most important thing, and I hope kind of a running theme in all the things we talked about, because all of these things provide different points in the older adults course that may prevent outcomes such as severe agitation and psychosis. But I also want to comment on the silent decade in maybe 50s, early 60s, before the actual onset of dementia, depression, or psychosis. About 1 in 5 older adults above age of 65 will have mild cognitive impairment. About 10 to 15% may change to Alzheimer's per year. So this is an opportunity for prevention. So being ambitious about prevention and treatment of risk factors is a very critically important thing in tackling this really growing healthcare concern. Identifying, referring for mental health or substance use treatment is very important, as well as preventative approaches with family, caregivers, and the patient themselves in home-based settings. I want to finish our talk with just kind of retouching on these negative bias and views, because these happen on multiple levels and can become internalized with older adults, even in the absence of mental health diagnosis. So these are things that we need to work on to focus on the positive elements of aging, which is resilience, wisdom, and conscientiousness. Social connectedness, critically important for the older adult. Loneliness and such are big factors for pathologic outcomes in older adults. So finally, our successful aging, defined by low probability of disease, high cognitive and physical function, that social connectedness being there, and active engagement with life and community is what we aim for. And those are all that I have to discuss with you today. Thank you.